Go ahead, please.
Okay. Okay, so I will present a case from Jackson South that it's affiliated to Ryder trauma. So we had a patient, 58-year-old male, unknown medical history, presented with a gunshot wound to the left chest. Per EMS report, the patient heart rate recorded at the field was 88 beats per minute. His systolic blood pressure was 130. His saturation was 95 on room air. He was tachypnic to 26 per minute. They started him on a non-rebreather O2 mask. His Glasgow was evaluated to be 11 and he was combative, hence he got IM ketamine and IV Versed. Upon arrival to resuscitation bay in our facility, he was unresponsive with Glasgow of 3. His saturation was 98 with a non-rebreather O2 mask with decreased breath sounds to the left chest. He was ill appearing, but he did have a palpable pulse. The first recorded vital signs was a heart rate of 64 and a blood pressure of 118 over 93. His pupils was equal, as I said, his Glasgow was 3. He had 2 gunshot wounds, one to the just lateral to the left nipple, and the second was at the mid upper back with a palpable bone fragment. His abdomen was non-distended, soft, and the right forearm grazed wound. So this will be my first stopping point to ask how to proceed from here.
Let's go to Atlanta. Dr. Frisbee, your comments, please.
Well, you started out with 88, you went down to 64, your pulse pressure is narrowed. If I was a betting man, I'd think you probably had a pericardial tamponade, but without a fast, I don't want to do that. Just get in a, start your lines and get an immediate thoracic fast and see if your heart's being crowded out with a lot of clot. That's the first thing I would think of.
Thank you, sir. Dr. Steuben? Go ahead, Dr. Steuben. Dr. Kasim?
Well, till proven otherwise, this is a box injury. And the complicating factor here is that he's been giving ketamine and Versed, and so he's not responsive. So you have to do everything. So clinical examination, a quick examination, quick rollover to make sure that there's nothing else in the back. And then of course, this has to be done in 10 seconds or something like that. And then you need to put your ultrasound on the pericardium to see if he's got pericardial effusion. And clinical examination again, and get your lines in and put the IV on the right side, not on the left side, because you don't know what you'll be encountering. And if you can get a chest x-ray, it'll be very nice. And there are 2 apparent gunshot wounds, and it looks like you should look for 2 bullets, unless there's 1 gunshot wound and 2 holes, which is unlikely in this case. So clinically, he is obtended because of ketamine and the Versed, and his vital signs are quite stable at this moment, but I didn't see how old he was. He's probably compensated. First thing you need to look for is to see if he's got pericardial effusion, pericardial collection of fluid, and the rest it can be taken care of at leisure. Of course, you should insert a left chest tube and to see how much blood he's going to put out from that. And also, it'll be not a bad idea if he's putting out a lot of fluid to at least think of autotransfusion if he's pouring out blood. So those are the thoughts I have. Chest X-ray will be helpful in the trajectory as well. So I'll stop there. Thank you.
Thank you, Dr. Kasim. Let's go to Iraq for Dr. Untrak's comments.
Yes, well, if he was shot by one assailant, then my guess would be it's a single gunshot wound with entry an exit, and so it sounds like entry probably in the front, lateral to the nipple, and then the trajectory was posteromedially. But in any event, he developed respiratory distress as he was becoming agitated. The agitation was probably because of the respiratory distress. So I think in this case, instead of waiting for the X-ray or even the ultrasound, I would put a chest tube quickly on the left side. He needs to be intubated. And then I would do the chest X-ray and a EFAST exam early on to rule out injury to the heart or pericardium. But I think with the rapid deterioration in his respiratory status, I think the chest tube would be, I would do that first and then proceed with the other diagnostic steps, chest tube intubation and the chest X-ray and EFAST and IVs. Yes.
Thank you, sir. Dr. Calderon, your comments, please.
Yes, this is a quick deterioration in a patient that we don't have any information about a head injury or previous intoxication. Well, he needs to be intubated and put under mechanical ventilation. He needs a resuscitation. I don't know if we have available chest an X-ray in the trauma bay, but at least I would go ahead putting a left chest tube, and I would do an EFAST. I need to check that pericardium because, as the colleague says, we have bullet wounds in the box. And I would take a look with ultrasound, the pleural spaces. We have some fluids. Well, let's see if something comes out from the chest tube. That's it by now. Thank you.
Thank you, Dr. Calderon. Let's go back to Washington State for Dr. Steuben's comments.
Hi, thanks. Yeah, I agree with all of our colleagues here and those things that I would do. I also have concern for, potential spinal cord injury, which may be contributing to not moving the extremities. Obviously, that wouldn't contribute to him not being able to talk, but he did get those medications, which could have an effect as well. And he has a midline wound with bony fragments in the upper back. So just want to keep that in mind as we go through our evaluation.
Thank you, ma'am. Dr. Donnelly joined us a few minutes ago. Sir, are you prepared to comment at this time?
Thank you, Dr. Johnson. I just arrived in contact and I didn't hear the presentation, so I shouldn't comment at this moment. Thank you.
Thank you, sir. Very good. I understand Dr. Lynn has joined us. Okay. Does anyone have any further comments before we return to Dr. Barda? Okay, back to you, Dr. Barda.
Okay, so what we did at that point was, so simultaneously, patient was intubated by the anesthesia team for airway protection. He got bilateral chest tube. There was no output on the right chest tube. The left chest tube drained hemopneumothorax. We did a FAST that was negative for pericardial and intraperitoneal fluid. He got a right femoral venous access and A-line placement, and we started him with blood transfusion. You can see here is the initial blood gathered. He was a minus 16 base deficit and the hematocrit was 34. At this point, the patient dropped his blood pressure to 69/34. And my question here would be, how should we progress from here?
Thank you, ma'am. Dr. Calderon, start with you, please. Let's go back to Washington State, Dr. Steuben.
I would want to know the heart rate associated with that blood pressure to help distinguish between types of shock. But I think repeating things like the EFAST would be prudent at this time.
Thank you, ma'am.
His heart rate remained the same, about the same.
Does that satisfy your question, ma'am?
Yeah, yeah, I think, we have to start thinking about need to go to the operating room, and probably if there's a mass transfusion protocol to start thinking about that. How much blood is in the chest tube at this point?
So this will be my next slide, but it was like 500 cc's.
Okay, so I mean, that shouldn't account for class 3 or class 4 shock, but again, we don't know if all of the blood in the chest has drained into the chest tube. So there's still some variables to figure out.
Thank you, Dr. Stubing. All right, Dr. Ontrat.
Well, yeah, so I agree with the last comment from Dr. Stubing about the volume of bleeding. If the chest tube is functioning and all the blood in the chest has been drained, and you're confident that he's not pouring out blood, well then, you know, I suppose that you can hold off on the operating room. In this case, I would resuscitate him, transfuse with blood to a systolic of about 90, and then try and get a chest x-ray rapidly in the trauma bay to see if the lung is expanded, if the blood is fully evacuated, and see if he stabilizes with resuscitation. If he doesn't stabilize and the injury is limited to the chest, I suppose if you can't resuscitate him, I suppose that you would need to go to the operating room. But the other possibility is, as Dr. Stubing mentioned, that he could be suffering a spinal shock if the bullet did hit the vertebral column and he is paraplegic, then that might account for the hypotension. If he's not tachycardic and hypotensive, it could certainly be spinal shock, and the treatment would be a depressor for that. So that's the thing to sort out, whether he's got hemorrhagic shock, continued massive bleeding into the chest, or perhaps spinal shock. That would be what needs to be settled out. So I would do the things I mentioned, the chest x-ray, and be sure that see whether the blood is fully drained, and then assess for possible non-hemorrhagic shock.
Thank you, Dr. Ontrat. Atlanta, Dr. Frisbee, your comments, please.
Yeah, I think that's the way to go. I mean, he's got a blood pressure with that blood pressure, his pulse rate ought to be over 120, 130, and it's not. The only explanation for that is he's got a flaccid bunch of vessels. Everything's dilating, and that's the definition of neurogenic shock. I would pour some blood into this guy to see if I could get that pressure up and get some pressors on him. I think you're right. That's probably where we're headed with this. But that's my only thought at this point.
Thank you, Dr. Frisbee. Dr. Kasim, your comments, sir. You're muted, sir.
I totally agree with Dr. Frisbee and the other colleagues, and Dr. Stubing caught that very early. Marvelous. And in hemorrhagic shock, typically the pulse rate goes up, but not always. Sometimes when you have a latent pericardial effusion, you can have both. You can have a hypotension with bradycardia as well. And so keep that in mind. So repeated examination is the key in trauma. We all know that. We need to repeat that pericardial scan one more time to make sure that we are not overlooked anything. And then after that, the treatment is again a transfusion and perhaps consideration to some type of vasopressor. In this case, start with norepinephrine infusion, test dose of that, or even phenylephrine test dose to see if you can get the patient pressure up. Thank you.
Thank you, Dr. Kasim. Dr. Calderon, your comments, please.
Yes, my apologies. I was in a phone call. Yes, neurogenic shock is a possibility, but we have to always rule out bleeding. So in this patient who is hypotensive without an increased heart rate, I will continue the resuscitation, very low transfusion, repeat the all the ABC, including repeating the fast examination and requesting the chest X-rays. If it doesn't give me any answer, maybe I would, I don't know if giving vasopressors or not, but this is the kind of patient that even being unstable, I will take to the CT scan to be sure if we have any spinal injury or any abdominal injury. Yes, thank you.
Thank you, Dr. Calderon. Dr. Donnelly, your comments, please.
Yes, thank you, Dr. Johnson. I'm considering if anybody would expect doing an emergency room thoracotomy, because as Dr. Kasim pointed out, we have to rule out bleeding, and probably it might have neurogenic shock associated, but I'm concerned about the bleeding. What was the EFAST positive for pericardial effusion or not?
The first one was negative.
And there was a second one.
This is the next slide.
Oh, I see. Okay, thanks.
Thank you, Dr. Donnelly. Any other questions before we return to our presenter, Dr. Barda? Okay, back to you, Dr. Barda.
Okay, so at that point, when the patient dropped his blood pressure, the output in the left chest tube was, as I mentioned, 500 cc's of blood. We did repeat the fast. That was negative again for pericardial and intraperitoneal fluid. At this point, we also did a chest X-ray, which you can see here. So you can see here with the clips. So this is one gunshot wound, and this is the other gunshot wound, apertures. We didn't have any missiles in the chest X-ray. The patient remained persistently hypotensive despite 3 units of blood. There was no change in the left chest tube output. He even had a repeat blood gases, which you can see here that the base deficit went down from -16 to -19, and his hematocrit trended up from 34 to 37. And I will ask again, what should we do now, given this additional information that I gave?
Yes, ma'am. Let's go to Dr. Ontrak in Iraq, please.
Yes, and during this time, his urine output?
We had a Foley, he had 200 cc's, like, we didn't, like,
Yes.
it wasn't
So
like
he was
accumulating. It was like in recess bay, it was less than an hour, all this occurring.
Okay.
So we had like the rest, but yeah.
Right. So the chest, the left chest is well drained. The lung is expanded, and there's no source of other bleeding. He doesn't have an injury to the heart or pericardium, and it looks like the bullet did not cross the mediastinum. So it was the upper mid back, but probably not across the mediastinum. And you say that there were bone fragments in the posterior wound, so that's likely an in to out wound. So that's likely an exit wound, sounds like. And so in this case, it looks like it's not hemorrhagic shock, but with, again, with no tachycardia, persistent low blood pressure. I think it's, and the location of the second wound near the thoracic spine, I think it's more likely to be spinal shock. And if he got enough volume, reasonably resuscitated, I might try some. Usually, it's neosynephrine for spinal shock works well. It's a good alpha agonist, and it would reverse the flaccid vascular tone, and see how he does with that. If he's not actively bleeding, that would be in that case my guess. And I would also call the neurosurgeon, see what they thought about this case as well.
Thank you, Dr. Untrak. Dr. Donnelly, your comment, sir?
I will go to now. I will go to the OR without dilation and see by myself if how was left chest, the lung, and the heart. It was wounded or not. I wouldn't do any other study. I will go directly for surgery.
Thank you very much, sir. Portland, Dr. Kasim? You muted, Dr. Kasim.
I am reluctant to go to the OR at this moment because I don't know what is causing his hypotension, and I kind of on the same page as my good friend Dr. Untrak from Iraq. I'm still thinking that this may be neurogenic shock rather than hemorrhagic shock. So on the chest X-ray, I would look for to see if there is any spinal injury from the second bullet, which went through, which was in the central area. Again, I will repeat the fast exam to make sure that I'm not overlooking the pericardial effusion, pericardial injury. I'm reluctant to go to the OR because I don't know what I'm looking at here, and it doesn't appear to me clinically that this is hemorrhagic shock. So therefore, I would hold my horses for the time being. A neurosurgical consultation will be a very good one as well, and I would get help from the neurosurgeon if they can add anything to this particular case. Resuscitating this patient, I think I would also slow down on my fluid. I don't want to drown him at the same time, and I would use the vasopressors of choice to get the blood pressure up to see if I can stabilize him. Without stabilize him, I'm very, very reluctant to taking the patient to the CT scan. Dr. Trunke used to say, if you want to kill this patient, send him to the CT scanner. And that aporium still holds for me. CT scanner can be very, very useful, but at the same time can be lethal, especially in a patient who is in shock. Thank you.
Thank you, Dr. Kasim. Washington State, Dr. Steuben, your comments, ma'am.
Sorry, my dog's going crazy.
Okay.
I'm concerned about the blood gas findings. With the PCO2 being very high, I wonder what the ventilator settings are, and if we can optimize that before going anywhere. I would like to go to the CT scanner because I think our likelihood of finding an injury, like a cardiac injury that is accounting for this, is pretty low, and I don't want to subject this unstable patient to anesthesia if he doesn't absolutely need it, especially with a pH of 6.9. So I would, try to optimize him for a trip to the CT scanner, because I think still my number one suspicion is a spinal cord injury with neurogenic shock.
Thank you, Dr. Steuben. Dr. Calderon, your comments, please.
Yes, the chest X-ray, I see that the left chest is well drained. He seems to have a very bad pulmonary contusion. But I will continue the resuscitation, now giving more pressure because the possibility of bleeding is coming down. And I would scan him. I would take him to the CT scan. Many people would disagree, but I need to figure out what is going wrong with the patient, and I don't think at this moment I don't think he's bleeding so bad. Thanks.
Thank you, sir. Atlanta, Dr. Frisbee.
Well, I appreciate all the comments. I think we're on the right track here. I'm hesitant to do two things. You don't go to the operating room on a hunch. I don't think that's a good idea. You got to have some reasonableness with it. And number two, I commend you for repeating this. You step back, take a step back, and look at it for what it is. I think this is neurogenic shock, and I think a neurosurgical consultation is appropriate. I've got a question. You say you've given this patient 3 units of packed red blood cells. Am I misreading this? It says sodium whole blood. Did you give him whole blood? Or is that just a laboratory?
No, this is like how it's.
Oh, that's
No,
the
we
laboratory.
didn't give him whole blood.
Yeah,
This
yeah,
is like the
understand.
report for the blood gases.
Right. But I think I would hold off on going to the OR. The CT scanner, you know, what my friend Dr. Kasim said is absolutely true. We used to call it the death room, basically because it was so far away from, so physically far away from everything that by the time you had an emergency there, by the time you got back, the patient's expired. But at this point, as long as he's holding on to whatever pressure he's got, or at least improving a little bit, we really do need an answer for this. And I think with the neurosurgical consultation and the CT scan, we might be able to find it. So that's my only comment.
Thank you, sir. I believe Dr. Lynn is in here, who was the attending on the case.
Yeah, I'm here.
Okay, would you like to comment, sir?
Well, I would like, well, I know what we did.
He was in on the case.
I was
He
in the
shouldn't
case.
comment.
There's nothing for me to comment. I'm very happy and actually with all the comments that were made, because all this thing about is he bleeding, is he spinal cord, CAT scans, OR, repeat, all what was said here was everything that went through our minds, Liran and myself, when this case was going on. So I'm very happy that everybody had the same kind of reluctancy and doubts on this case. And I know what we did finally. So let's continue with this Sherlock Holmes kind of presentation.
Yes, sir. Thank you. We just had another doc join from Jackson, from Ryder, having trouble with your video. Who just commented?
Who, me?
Yes, sir. You. I'm sorry. I can't see you. Sorry.
Dr. Ginsburg.
Yes, sir. Hey, Dr. Ginsburg.
You're having trouble with the video?
No. Okay. Yep. I'm
I
fine
see.
now. That was on my end. You're good. Thank you. You're beautiful. Thank you. Your comment?
I missed the first part of this case. I just heard, you know, you've got hemothorax with penetrating trauma to the left chest. Was it in the box or not in the box?
It was just lateral to the left nipple, and the other bullet hole was in the midline posterior, like upper back.
So it was border, Ginsburg, just to let you know, it was at the border of the box.
Mm-hmm.
Nip, like maybe what, Liran, a centimeter,
Yeah.
like left to the nipple, but it was like at the border of the nipple, basically.
Yeah.
But it crossed, were you suspecting, did you think it was in the box? If I thought it was in the box and I had hypotension, then you know what I would do. I would go and get him into the OR and do a pericardial window on the patient and just and resuscitate him while he's in the OR. But that's my approach to in the box with hemothorax, because as we all know, an ultrasound, a fast exam, has a 20% chance of false negativity for hemothorax in the box.
Okay.
Yes, sir. Any other comments before we return to Dr. Barda in the presentation? Okay, back to you, Dr. Barda.
Okay, so as it was already said, so we were also very concerned of neurogenic shock, but still, because of the location of the gunshot wound and the hemothorax on the left, we decided to take the patient to the operating room to rule out a cardiac injury. The patient continued to get blood products. He was initiated on pressors for the possibility of neurogenic shock, and we did a pericardial window, subxiphoid, which was negative, I will state that the peritoneum was opened inadvertently, but there was no protrusion of blood. We didn't formally explore the abdomen. At this point, the left chest tube output had non-significant increase in output. This is blood gases that was before the surgery, but in the operating room, and here you can see the patient vital signs. So as you can see here, he was getting FFPs, he was on a norepi drip, and he was relatively, like his MAPS was around 80 at this point in the operating room after the pericardial window. Unfortunately, I don't have another resus that was taken in the operating room, but I would stop here now and ask, how should we progress from here?
Thank you, Dr. Barda. Atlanta, Dr. Frisbee, your comments, please.
You got a dual purpose room there?
Hybrid? No.
I'd get him down. I think I'd take him to the CAT scanner. I really would. I got to find out where the, is that one, you've got two holes. Are they both entrance, or is one an entrance and one an exit?
No, it's an entrance and it's a single gunshot wound.
Yeah.
That we thought came anteriorly and went like mid-back.
Right. So it's hit something in the back and it's gone out, glanced and gone out, ricocheted off the bone and left the body. You know, frankly, I think I need a CAT scan to see that spinal column. But that's my only comment.
Thank you, Dr. Frisbee. Dr. Calderon?
CAT scan. That's it. Thank you.
Thank you. Washington State, Dr. Steuben, your comments, please.
I certainly agree that this patient needs a CT scan. You know, his blood gas is marginally better, but I'm you know, still concerned about his acidosis, which is partially respiratory in nature. So I think we could ventilate him a little better to help fix that and help the pressors work a little better. But he absolutely needs to go to CT.
Thank you, ma'am. Iraq, Dr. Untrak, your comments, sir.
Well, about the blood gases, it looks like he has a respiratory acidosis. PCO2 is 54. So he's not being adequately ventilated. So the issue is whether there's an occlusion in the bronchus, if both lungs are actually being ventilated. He has breath sounds bilaterally now at this point.
We didn't check for breath sounds. He was ventilated.
You did. But he's hypoventilated according to the PCO2. But in any event, his blood...
He was 74 on the previous blood gases with a pH of 6.9 and PCO2 was 74. So essentially these blood gases are a little bit better. Like I agree, he has respiratory acidosis. But...
Okay, and in any event, his blood pressure now looks like it's stabilizing. It's better on the pressors, and I would just optimize his vital signs with the pressors, and I agree to take him to CAT scan of the neck and the chest and through to the upper abdomen, but with intravenous contrast CT.
Thank you, Dr. Untrak. Let's go to Portland. Dr. Kasim, your comments, please.
So I have one question to the presenter. When you did a pericardial window, did you observe anything at all? Did you see something? There was nothing, no blood whatsoever.
No, the pericard was clearly negative. It was like clear fluid in the pericard. There was no blood. We didn't have any doubt.
Right. Well, there is a case report of a case where the patient had a hole in the pericardium and he was bleeding, and the blood, instead of accumulating in the pericardium, was effusing out in the left pleural cavity, and it was accumulating in the left pleural cavity. And you will have the same picture like this. But I am more of the opinion, as my friend in Iraq, that this is probably neurogenic. And first of all, you're taking too long to correct the respiratory acidosis, and I think that can be corrected. That should be corrected rather fast than allowing this to go on, because we are in a confusing situation there as well. So I'm still thinking neurogenic shock, and I still don't think the patient requires any surgical exploration, because I don't think he's bleeding to cause this problem. And so CAT scan to look at the spinal column would be the first thing that I would go to. I hope I'm not missing something. That's what I'm worried about.
Yeah, that's what we all hope when we deal with these cases, doctor, that we don't.
Yeah, I think I think I'm missing something here that I can't put my finger on. Sorry. That's my gut feeling.
All right. Thank you, Dr. Kassim. Dr. Donnelly?
Yes, thank you. Well, I congratulate people that wouldn't have done a thoracotomy and still think he has a neurogenic shock. I also believe he probably has a neurogenic shock, but I would, in my place, I would, if I had this patient again, or this kind of patient, I really don't know his age, but it doesn't matter at this moment. In my, sorry?
58.
50. Okay, thanks. In my place, I would again wouldn't hesitate in doing a thoracotomy, an anterolateral thoracotomy, because I want to be sure, absolutely sure, that he has no bleeding problem in the lung or in the chest or in the heart. Studies fast is very good. You can repeat the fast, but I would like to see it by myself with my own eyes. I wouldn't have done with this patient pericardial window in a patient in shock. I believe it's pericardial window is very good, but a patient who has time, you have been resuscitated and stabilized. But at this moment, if all the vital signs have gone normal, probably I would do a CT scan. Thank you.
Thank you, Dr. Donnelly. Go to Ryder, Dr. Ginsburg. Your comments, sir. I think he's finding his getting to his mute button.
Oh, sorry.
Okay.
As Mauricio stated and others, I mean, the most uncomfortable thing is to have to make the diagnosis of neurogenic shock and be uncomfortable that there might be some misbleeding. So in this type of situation, before I would send them to CAT scan, you've ruled out basically exsanguination in the belly because you inadvertently got into the belly, which turned out to be a good thing. In that there was no welling up of even a spot of blood. Pericardial window was completely clear. If there was an injury to the heart, there would be at least a little bit of staining of blood, even if it had decompressed into the left chest. The only other thing before just saying, okay, it's neurogenic shock, while he's in the OR, I might say, okay, I'm going to send him to CAT scan, but just to be 100% sure, let me get what's coming out of the chest tube. I didn't see what was coming out. Even if nothing was coming out of the chest tube or very minimal, I would possibly do a quick chest X-ray in the OR, possibly resuscitate him a little bit more, waiting for the CAT scanner before sending him off to CAT scan to see if it was spine injury, which it sounds like it is.
Thank you, Dr. Ginsburg. Dr. Lin, anything to add before we go back to Dr. Barda?
No, I think Dr. Barda has it all. Great presentation, so let's continue.
Yes, sir. Back to you, Dr. Barda.
Okay. So we elected to take the patient to the CT scan, and I have it in two windows. So this is the lung window. And I will go to the abdominal window, including the abdomen scan. You wanted like to repeat it, or were you able to look at, like, to see it?
Anyone?
For me, it's okay.
Excuse me, do you have a bone window?
I don't have a bone window, but I can repeat this one and you can see the bone fragments that we saw. I will just scroll this again. Here. The spine was intact, just for.
But that left chest, if you would have done a chest X-ray in the OR, you'd see that he was full of blood. It looks like, correct?
Mm-hmm.
So now we're sitting in the CT room. We're actually looking at the CT scan while this is being done. And now I know Liran is going to ask the same question, but so now we are sitting there looking at this. We know it's not spinal now, and the chest is full of blood. So we have to make a decision. Where do we go? We go to the ICU. We go to the OR, right, Liran?
Mm-hmm.
So that's the next question, right, Liran?
Yeah.
Is your next slide?
Yeah, here you see the question mark. So what to do next? With this CT scan, the results, what to do next? Where should we go?
Okay, let's go to Iraq. Doctor on track?
Well, if you've ruled out a spinal injury and the left chest is full of blood and he still his blood pressure is coming up a little bit, but on pressors, then I think, you know, as Dr. Donnelly said, in this case, I would do a thoracotomy on the left side. If this really localized, you've ruled everything else out, and if the chest tube is not functioning, you could put another chest tube in to see, you know, if it pours out blood, and you know, but if you know that the chest is full of blood, and I think it's reasonable to go back to the OR, do a thoracotomy.
Thank you, Dr. on track. Dr. Calderon, your comments, please.
Yes, exactly. We must take back the patient to the OR to do the left thoracotomy.
Okay.
Yes, I have nothing else to say.
All right, thank you, sir. Dr. Donnelly?
Yes, at this moment, what we could do, what I would do probably is an angio CT, a quick angio CT, and then go to UR. Probably it's an aortic. Probably could be an aortic laceration. I don't know. If you could do an angio CT, I would do it at this moment. If not, I will go to the UR. correctly. Thank you.
Thank you, sir. Atlanta, Dr. Frisbee.
Ruled out just about everything. It's time to go to the operating room, especially if you've got a CAT scan that shows the left side, this chest cavity is full of blood. It's probably clotted by now, but that's what I would do.
Thank you, Dr. Frisbee. Portland, Dr. Kasim, your comments, please. Muted, Dr. Kasim.
If this patient has had an aortic injury, he would have been dead by now, in my opinion. So I think he has a left lower lobe trapped with clots, and he's bleeding in that area. You've already given him blood product, and pressors, and the dictum is stop the bleed. Take him to the OR and stop the bleed. And you may have to do a formal left lower lobectomy.
Thank you, Dr. Kasim. Dr. Steuben, Washington State, your comments, please.
I think I agree with going to the OR. I can also see the concern for potential aortic injury that, may have been, sort of broken more free than on the initial chest X-ray. Although it's unlikely that that's, I think, still not the most likely scenario. If there is a hybrid room available, that would be ideal. If you do find something like that in the OR during a left thoracotomy, but I think left thoracotomy is the way to go. And also, just wondering if there's any bloody secretions in the ET tube, if there's an obvious airway injury or anything like that that could clue you in.
Thank you, Dr. Steuben. Ryder, Dr. Ginsburg, your comments, please.
Basically, did I hear he was on pressors during this time?
Yes.
Yeah, I mean, there's no choice here. If he's on pressors, then you've got to take him back to the OR. That's the only reason I made that other comment. I was kind of surprised. I now remember this case, I think, being presented, but just to go back for a discussion, which I brought up, before going to the CT, if you would have done a chest X-ray, gotten resuscitated, if he had the left chest full of blood, but was off pressors, then maybe I think going to CT just to delineate would have been a good idea. But if you had a chest X-ray with a lot of blood in the chest and you're not able to get the guy off pressors, then the question is, do you keep him in the OR, put another chest tube in, or just open him up at that point? But at this point, I don't think there's any choice. You got to open him up.
Thank you, Dr. Ginsburg. Dr. Lin, anything to add?
Nope. Let's Liran do the final. The stage is Liran's stage, so go ahead.
All right. Thank you, sir. Did everyone who wished to comment have an opportunity to do so before Dr. Barda resumes?
I'm just going to make one comment on my comments. The thing is, as Mauricio and Liran know, sometimes it takes a half hour to get a chest X-ray in our OR. In that amount of time, you can actually have your answer from the CT and be back in the OR. So I don't fault them in what they did. Just going through the process.
Thank you, Dr. Ginsburg. Back to you, Dr. Barda.
Maybe just like to add another question before I progress, because it will be like the final case. But what surgical approach would you choose for this patient? Like the people that say that they will take the patient to the operating room.
Okay. Dr. Steuben?
That's actually something that I was going to talk about earlier as well and forgot. I think, if you didn't have the CT that and the, incidental sort of negative peek into the abdominal cavity, you would have to be supine in order to quickly explore the abdomen as well. But I think if your CT is negative for abdominal injury, then it's probably safe, and you already have a negative pericardial window, it would be safe to put this patient with the left side up to do a better thoracotomy.
Thank you, Dr. Steuben. Dr. Donnelly, your comments, please.
Yes, referring to the incision, in the first place, what I would have done is an anterolateral thoracotomy with a left posterior support, because to manage the majority of lung, hilar, and cardiac wounds, lesions. Sorry, but if you have a suspicion about an aortic dissection or laceration, the ideal is a posterolateral incision. Obviously, I think in this case, the posterolateral is very good for posterior mediastinum and aorta, but it limits your exposure. So after the CT, probably I would do a posterolateral. But in the first place, as I said, I would do an anterolateral with a posterior support, left posterior support.
Thank you, sir. Dr. Kasim?
It depends how you look at this case. If you think that the patient has a cardiac injury and he's leaking through a hole in the pericardium and the left pleural cavity is filling up with blood, and the best approach would be a clamshell type of incision, so that you can look at the heart as well as the left lung. But if you're absolutely sure that the cardiac injury is not involved in this case, then to do a good lung resection, posterolateral thoracotomy will be my choice. Thank you.
Thank you, Dr. Kasim. Dr. Calderon?
This is another tough question. Yes, I'm having in mind lung injury, great vessels injury, cardiac injury, but I need to be very fast because we already lost a lot of time with these patients. This is what would I do? And even with that, I am not sure if I'm doing the right thing. I would start with anterolateral left thoracotomy, and I can always convert it to a clamshell, right? Just to have access to the mediastinum and the heart. And let's see. Thank you.
Thank you, sir. Atlanta, Dr. Frisbee, your comments, please.
Well, I agree. I think if you're thinking about good exposure to the pulmonary vasculature, you need a posterior approach. So I think I'd start with the left anterior thoracotomy and be ready to convert it a little bit, either a clamshell or a posterior aspect. But I don't have anything else.
Thank you, Dr. Frisbee. Dr. Ontrat?
Yes, well, the trajectory is anterolateral to posteromedial or posterior midline. So I think in this case, you need access to the posterior mediastinum, and with all the prior workup and the pericardial window, I would do a posterolateral thoracotomy in this case.
Thank you, sir. And Dr. Ginsburg?
Posterior lateral.
Thank you, Dr. Ginsburg. Dr. Lynn, I'm assuming you want to go back to Dr. Barda?
You assume correctly.
Yes, sir. Thank you. Back to you, Dr. Barda.
Okay. So we took the patient back to the operating room. So immediately when he was transferred to the OR table, the anesthesia team had difficulty ventilating and oxygenating the patient. So we immediately inserted the additional left chest tube, and the patient vent setting was improved. We elected to do a left posterolateral thoracotomy, and we were able to evacuate around 3 liters of retained hemothorax. He had a gunshot wound aperture to the superior aspect of the left lower lobe with active venous bleeding. We did a tractotomy followed by a partial left lower lobectomy and 2 figure-of-8 suture for hemostasis. He had also active bleeding from posterior chest wall that we did hemostasis control for. We placed 2 chest tubes and closed the chest. In the end of the case, we did a bronchoscopy. And there was a small to moderate amount of dried blood in all airways, but there was no occlusion and no active bleeding. And the patient got a total of 8 units of blood, 7 units of plasma, 1 platelets, 1 cryo, and 5 liters of crystalloid throughout all his course during surgery and in the ED. He was transferred to the ICU and on a low dose of pressors. This was his chest X-ray post-procedure. He was able to be weaned off pressors after additional unit of blood in the ICU. So essentially, he was weaned off pressor in POD 0. He did have a CT scan done for altered mental status, but the CT scan of the head was negative. It appears that the patient had psychiatric history and also drug abuse. He was started on antipsychotics and he was able to be extubated on POD 2. His BAL was positive for Acinetobacter, so he completed an antibiotic course for 10 days. His chest tubes were removed gradually, and all chest tubes were out by POD 5. He did have an AKI with creatinine up to 3 that went down and resolved by POD 3. He never needed a renal replacement therapy. On POD 8, the patient had a spiky temperature and leukocytosis with some consolidation in the left chest that was concerning for infiltrative process, and his antibiotic coverage was expanded, but the patient was able to be discharged home on POD 13. And that's it.
Great job, Liran. Great job.
Okay, Dr. Barda, are you ready to go around for final comments?
Yeah, sure.
Okay, very good. Atlanta, Dr. Frisbee?
Nice case. Very, very well done. We finally got there. Finally got there. But it was really educational, very instructive. Thank you so much.
Thank you, Dr. Frisbee. Dr. Untrak, and all right, your comments, please. Final comments. You're muted, sir.
Yes, excellent case. Just very instructive about doubling back and retracing your steps. And so it looks like the initial chest x-ray, we were a little bit fooled. It looked like the chest had been fully drained, and apparently there was accumulation of blood, likely from the very beginning, that wasn't being drained. So that was the issue, but all ended well. Excellent job.
Thank you, Dr. Untrak. Washington State, Dr. Stubing, your final comments, ma'am.
Yeah, it's a great case, a lot to think about. I think the one thing that I think I should have thought a little more about was why the PCO2 was so high. I think if we paid more attention to why he had such a profound respiratory acidosis, that may have pointed us in the direction of a lung injury earlier.
Thank you, Dr. Stubing. Dr. Calderon, your final comments, please.
Very interesting case. I'm really impressed. I feel like in the action movies, honestly. Because I know the initial decision in this case was very difficult. Take the patient to the OR, take the patient to the CT scan first. And I don't have a hybrid room in my hospital, so I would have to take that decision and have 50% of possibilities of taking the right decision and 50% of just going back to the outer room. So we just have to take a decision. That's what we did. Well, but if we decide to take the patient to the OR, we have to open him up, just do the whole thoracotomy and do the laparotomy to take a thoroughly looking at both spaces. Well, it's very nice case. I learned a lot of lessons today. Thank you.
Thank you, Dr. Calderon. Portland, Dr. Kasim, your final comments, please.
Great case. Learned a lot. But I've seen this movie before, and I was going to ask Dr. Ginsburg. You know, you do chest X-ray, you put a chest tube in, and yet there's accumulation of blood in the chest cavity. Somehow doesn't seem to show with all the stuff that we have. How do you go about determining that the patient is bleeding? I've seen a case like this in the lung itself, and the lung kind of became like almost like the liver.
So
Missed that.
Before Dr. Ginsburg answers, this is Dr. Lin. Let me just say one thing. From
Sure.
the first CT scan, from the first X-ray, after the chest tube, where it shows a relatively clean left lung, to the CAT scan, we went through, just a reminder, we went through to operating room to do the window, because we always do that in a patient that has a left hemothorax with a box and penetrating injury. So we went through the OR for window, and then he went for CAT scan, and then on the CAT scan we saw that. So I don't think the chest X-ray missed anything, the initial one. It just a matter that it took some time. He continued to bleed from his lung, and he continued to bleed from his chest wall, and that's why there was the accumulation on CAT scan. Because I don't know, I'm not sure Liran shows the timetable, but I think roughly from the first X-ray to the CAT scan, there were probably some 2 hours. And that's why there was the accumulation of blood. I don't think the X-ray missed, but I'm very happy to hear what Ginsburg has to say.
Okay, Dr. Donnelly?
Yes, very, very interesting case. Excellent surgical damage control management of the lung. Congratulations.
Thank you, sir. And Dr. Ginsburg, your comments, sir.
My comments from Dr. Kasim and Dr. Lin, the only thing you have to rely upon for Dr. Kasim is really your chest tube and an X-ray, or a CT scan, which is what was chosen to be done in this case because there was a low suspicion at that time for continued lung bleeding from the presentation of all the X-rays and everything that was going on. So in this case, I think things were done correctly. And you were assuming that it was a spinal cord injury, and you had a chest X-ray post-chest tube, right? That was clear. So this is just one of those rare cases where, patient continues to bleed, accumulates blood, and your chest tube is clotted. So that's the only reason I said, initially, when you were done with the case, if the guy's still on pressors, yeah, if you could, I'm thinking retrospectively now, so it's easy for me to just say, I'd order a chest X-ray and just make sure that things were clear. If it was full of blood, then the real question would have been, on pressors, would you have taken him to CT, or would you have just put him on his side and opened him up at that time? But Liran, from this case, the most important thing is, after thinking about it, because I'm never fully satisfied with any case that I do, I always think there might be something better, but maybe in this case, things were done correctly for you completely. Is there anything that you would have done differently, or were you satisfied with everything?
No, in the end, I think I can rationalize every step that we did. So I feel comfortable with our management, in the end of the day.
Okay, well, that's all that counts.
But Ginsburg, the truth of the matter, Iran was pushing to get this patient to the operating room, I think, to open his chest after the window. And that's the truth. And I said, no, let's go to CAT scan. So she was she wanted actually to be more aggressive, which ended up being what we actually did. We did a thoracotomy, but she wanted to do this thoracotomy a step before it was actually done.
And why? Liran?
Because to me, like the way that I was taught is that you always need to be like to rule out bleeding. Like before, like when, like I understand that you have a differential diagnosis with neurogenic shock, but like is base deficit. So yeah.
But that was not the issue. The issue was that the chest tube was clotted, but nevertheless, the hemoglobin went up. And so that's why I felt comfortable to scan him. I didn't think the guy was exsanguinated because after 2 or 3 units of blood, the hemoglobin actually went up. So that was our kind of discussion. And it was right. I don't think we should have, if we would have taken him, it wouldn't be nothing wrong. The only thing that I thought was better is that after the CAT scan, we knew where the bleeding was most likely coming from on the posterior chest wall, and a posterior lateral instead of an anterior lateral gave us a great exposure.
Yeah,
so I thought that was the only thing that probably the CAT scan gave us more information. That we would have done an anterolateral if there was no CAT scan, right, Liran? That was the idea.
Yeah.
Yeah, because the patient was laying down and you wanted to just get it done. But in reality, the posterior lateral gives you the best exposure. Mauricio, what you were saying with regards to, I probably would have done the same thing. Send him to CAT scan if the patient's hemoglobin had gone up. And the only thing that was, if the hemoglobin had gone up and you were basically not so suspicious that he was continuing to bleed. So I would have done the same thing. And the reason that I'm surprised you didn't mention is that here's a guy who's in neurogenic shock, possibly, you don't know, who's lost some blood. And a thoracotomy is not just a simple benign procedure. But as Liran stated, if you're thinking that he's bleeding in the chest, obviously that's the most important thing to take care of. A very good case, interesting case, and obviously the thought process was well explained, and that's the more important part.
Do we have any more questions or comments before we close the session?
Could you give us a quick explanation to the blood gases?
Okay,
Dr. Barda or Dr. Lynn?
I'm going to leave the meeting. Thank you very much for all the comments.
Thank you, Dr. Lynn. Was that a question for Dr. Barda, Dr. Kasim?
Yes.
So
the blood gas finding.
With the base deficit that was so significant, I think it was also maybe mixed with some intoxication when he presented. He was actually, I think I have it, he was able to correct his blood gases, but it took it a while. Let me just, 1 second, I will share my screen. So you can see here, so this blood gases was when he went back from the OR to CT scan. So you can see that he has like the PCO2 that we saw that was a little bit like improving, was still like he did have like very difficulty ventilating him. At this point, anesthesia is handling his vent setting and everything. And you can see that his base deficit was corrected for some degree, but his hematocrit went down at this point. Like this was the point that we opened his chest. So we put the left chest tube, and if you remember the CT scan, so he did have like a pneumothorax on the left, and I think he also had some compression of his heart in that CT scan, like it was relatively like tension, kinda. When we transferred him to the OR table, so and essentially the left chest tube that drained initially, we did it more anteriorly, and it drained like pneumothorax, and the patient improved. Then we turned him to the side and did the posterolateral. but you can see the significant respiratory acidosis that is marked here with, like, in the end, he did have his hematocrit going down. So I think it was a combination. Yeah, but it was also confusing to us because, like you saw it, he never was tachycardic at no point, like he was tachycardic. His base deficit was significantly low from the beginning, like -16, and with resuscitation it went down to -19, and the hematocrit did trended up, like 34 to 37. It's possible also because we gave him blood, he didn't have time to dilute his blood. And in the OR, he did get like more crystalloid, then maybe the hematocrit did show signs of trending down, but at this point he was like better resuscitated, so the base deficit were able to correct. And at this point, like I think one of the participants mentioned, the problem in ventilation that maybe is attributed to his like mainly lung pathology.
Let me ask you something, Liran. Since Mauricio wanted to send him to CT, you wanted to open the chest. Did you discuss?
No, so at that point, no. So I wanted to open the chest. It was in the beginning, but then at that point when we were in the operating room and the pericardium was negative, and we talked like I said, like, don't turn on, like turn off the, like turn around the room, like just wait for us because maybe we will come back from the CT scan. This was my point. So this was like our disagreement that like they closed the room, but then they open it again. So we brought him back from the CT scan.
Let me ask you something. Did you even, since you thought that there might be bleeding in the chest, did you discuss putting another chest tube in the chest to see if he had bleeding? So let's say you had put another chest tube in the lung and it started pouring out blood. You wouldn't have done anything. You would have just flipped him over and opened his chest, right?
Possibly, it depends also on the amount. Like I agree that doing a chest x-ray, like in retrospect, maybe if we would have done the chest x-ray, we would.
You would have seen a whiteout, and then you would have put a chest tube in, right? Mm-hmm. You would have put a chest tube in, and if you had like a liter coming out of there, or a liter and a half, you probably would say, now let's just open the chest before we send them to CT.
Yeah, and it's possible also that another chest tube would not have drained because also the additional chest tube that we put, it drained the air, but it was not able to, because most of the blood was clotted. So I think the patient would end up having thoracotomy. The fact that we were able to take him to the CT scan and to rule out a neurogenic shock and also to position him in a way that made our surgery like easier.
Yeah.
And yeah, luckily the patient didn't suffer any.
It went well. It went well.
That. Yeah.
Interesting case.
Yeah.
All right. Thank you.